So, standard precautions. The idea is we are assuming that every person we come in contact with is potentially infected or colonized with an organism, and that it can be transmitted. So we just assume everyone has an infectious disease, and we take very standard precautions to prevent the spread. Okay? And there's two key components to standard precautions. Number one, most important, nothing else works unless you have good hand hygiene. Okay? So avoiding unnecessary touching of surfaces or unnecessary touching of patients, and performing good hand hygiene, meaning frequent washing of hands with soap and water, or at the very least with alcohol or hand sanitizer. Okay, so hand hygiene is the first and foremost step for all infection control. Additionally, we have the use of what we call PPE, or personal protection equipment, and they include things like gloves, gowns, mouth, nose, and eye protection. So under standard precautions, we are using gloves if we're going to come in contact, our hands are going to come in contact with blood or any bodily fluids. Okay? Whether we're assuming everyone has the disease that's transmissible, so if we're going to come in contact with blood or bodily fluids, we're going to use gloves always. Okay? We're going to use gowns if we're performing some procedure where we anticipate the contact with blood and bodily fluids. Okay? Where blood and bodily fluids can actually be sprayed and enter and get on our clothing or something like that. So we're going to wear gowns depending on that. And then additional PPE includes covering the mouth, the nose, or eye protection if we think that the procedure we're performing on somebody can cause the splashing of blood and bodily fluids onto our mouth or our eyes or our head. Okay, so the use of personal protection equipment is setting specific and activity specific. But under standard precautions, if we're going to come in contact at any of these levels with blood or bodily fluids, we're going to use this equipment to protect ourselves. Contact precaution, okay, in addition to standard precaution, is used when we have a patient. Now doesn't have to be assumed. We know that a patient has an infectious disease that is transmissible by direct contact with bodily fluids. Okay, so a person, for example, has a wound on their leg that is infected with methicillin-resistant staphylococcus, MRSA. Okay, now that patient is going to be put on what's called contact precautions, and that means that they're likely going to be put in a private room so that they can't infect their roommate. Anyone entering the room is going to have to wear gloves and gowns. Okay, anyone entering the room is going to wear gloves and gowns. Anyone entering the room, right, this is part of standard precaution, is going to wash their hands immediately before and after they put on their gloves and gowns. We're going to limit transport of this patient outside of the room so that we limit opportunity for spread. Also important, any equipment that we use on this patient, we're going to prefer to use disposable things, or we're going to use things that are left in the room. So for example, your stethoscope, many nurses and doctors, they carry their stethoscope that they prefer to use around their neck, and they use it from patient to patient. And of course they are cleaning the stethoscope between patients, or at least they should. With contact precautions, there's going to be a stethoscope in the room that never leaves that is going to be used on this patient, okay, to prevent the spread of this disease from patient to through the movement of the stethoscope out of the room. And then environmental measures. This room is going to be prioritized for frequent cleaning and desanitation. Okay? That's contact precaution. One step up from contact precaution, and it piggybacks on contact precaution, is droplet precaution. And this is when a patient has a disease where blood or bodily fluids can get aerosolized in the air, right, into these droplets in the air through things like sneezing or coughing. Okay? And so with droplet precaution, in addition to standard precaution, and really in addition to contact precaution, we're also going to have people wear a mask, okay, to prevent the droplet from being inhaled or ingested into the person's nose or mouth. Okay, so droplet precaution on top of standard and contact, the person, anybody, everyone who enters the room, in addition to gowns and gloves, are also going to wear a mask. Okay. Airborne precaution, this is where those aerosolized droplets, okay, the particular disease now is so easily transmitted that the droplets can be so tiny, and the pathogens suspended in those droplets can persist in the air. They can linger in the air for a long period of time, and they can travel a long distance. So basically breathing the same air as this patient is leaving anyone highly susceptible to acquiring the disease. So with airborne precautions, it's the highest level of precaution. It's building on standard, contact, and droplet. The patient is placed in a private room, and the door is always closed. And this room is a special room. It's a room with negative air pressure, which means that the air in the room is actually constantly getting sucked out. And basically, between 6 to 12 times an hour, the air that occupies this room is going to be completely refreshed. So, and that we have HEPA filters that are used at the suction point and the re-entry point for air circulation. Okay, so this patient private room, every hospital has at least some of these negative air pressure rooms, they're basically maintaining a very carefully controlled air quality. In addition to that, right, with airborne precaution, everyone who comes in the room is also going to wear a very special kind of mask called an N95 respirator mask. Okay. Now this N95 respirator mask is actually something that needs to be fitted from person to person. So you are fitted to make sure that there's no opportunity for air to get around it. It specifically fits your face. Okay. So in addition to the negative air pressure room, you get this very individualized, customized respirator mask. And the movement of the patient is highly limited. Okay? Everybody comes to the patient. So those are the levels of precaution that you will observe in a hospital setting. Now, when we treat infectious diseases, we use a whole host of drugs that are called antimicrobial drugs. And this includes drugs that are used to fight viral infections, drugs that are used to fight bacterial infections, fungal infections, and the entire spectrum of microbial drugs. Now, there's an interesting thing that happens with the use of antimicrobial drugs, and that is whenever we use a drug like this, what we're actually doing is creating evolutionary pressures for the microorganisms to actually adapt and develop a resistance to the drugs. Okay? And this is something that happens rather quickly because bacteria and viruses, for example, they can mutate and evolve very, very quickly. Their evolutionary time is on the order of days to weeks. It's not, centuries to millennia like humans. They evolve very, very quickly. So what we've found, and it's a growing problem worldwide, is the how common the appearance of antimicrobial resistance is. And this is true for resistant viruses and resistant bacteria. But what we tend to talk about a little bit more is the development of antibiotic-resistant bacterial infections. So in this slide here, what we're looking at, just to really drive home the idea that this happens really all the time and it happens quickly, is if we look at the history of the treatment of Staphylococcus aureus, a very, very common bacterial infection. The very first antibiotic ever developed, penicillin, 1941. Within a year of the development or introduction of penicillin, we first started to see penicillin-resistant Staphylococcus aureus. Okay, and then the different generation of drugs that were developed subsequent to penicillin to fight Staphylococcus aureus, streptomycin, tetracycline, erythromycin, gentamicin, methicillin, right? They were all introduced at later dates from 1941, and within a couple of years of their introduction, we first started to see resistance to those drugs. So resistance develops quickly, and it develops nearly universally, okay? And that really presents a problem. But what we definitely know is that the more we use an antibiotic, so the more overuse and inappropriate use of an antibiotic there is, the faster and more widespread the development of antibiotic resistance there is. So if we project by the year 2050, what we see are astounding numbers of deaths projected deaths attributed to antimicrobial resistance worldwide. Okay, so this is really a worldwide problem. And if we look at, from the perspective of a pathogenic bacteria, what we see is that what they develop in order to become resistant to antibiotics is a variety of strategies to basically evade these antibiotics. So these are just some examples. So here we've got our bacteria, and some examples of how the bacteria managed to become resistant is in, for example, decreasing the influx or the uptake of the antibiotic. So sometimes antibiotics require a binding to a receptor on the cell in order for the drug to be taken up. So some bacteria just reduce their expression of those receptors, so the bacteria doesn't enter. Another very, very common mechanism for resistance is inactivating the antibiotic. So the antibiotic enters, but the bacteria has developed an enzyme that actually breaks it down before it can attack the bacteria. Okay? So the bacteria develops, there's a gene that mutates, and it develops this gene that can code for an enzyme that breaks down the bacteria. Okay? Sometimes bacteria will just, as the antibiotic enters, it will just push the antibiotic out. Right? It's a process called efflux. Okay? Sometimes the target that the antibiotic has inside the cell, the way it fights the bacteria, the bacteria just modifies the target so the antibiotic can't recognize it, or it just boosts that function so the antibiotic actually can't overcome that amplification. Okay, so lots of different ways or lots of different mechanisms that we've identified for bacteria to be able to resist antibiotics. And if you notice, these are in the white boxes, they're example antibiotics for these different mechanisms. And if you notice, there's one name that comes up over and over again, beta-lactams. Okay, so beta-lactams over here, beta-lactams here, here. The beta-lactams include the family of penicillins. So the beta-lactams are the oldest category of antibiotics, and as you can see, bacteria have developed the greatest number of mechanisms to evade beta-lactams, which doesn't mean that they're not still effective. It just means that it just sort of drives home this idea that the more experience bacteria have with an antibiotic, the more it will develop, more likely that resistance will develop. Now, this idea that the more overuse or inappropriate use of antibiotics, the more likely we see resistance, we normally actually think about this in terms of clinical practice. We think about it in terms of medicine, that when you are sick and you go to the doctor and you insist on getting antibiotics, even though you have a viral infection and the antibiotics can't fight that viral infection. So that does increase the likelihood of resistance. However, if we really are honest and we look at the annual estimated antibiotic use in just our country, okay, what we find, the red piece of this pie is all antibiotic use in humans. And then the blue piece, which is the vast majority of this pie, is antibiotic use in livestock. And in fact, the vast majority of antibiotic use is in agricultural settings. So, and it's not even always to treat ill animals. There's actually many, many examples of the use of antibiotics on animals that are not ill, right? They're used for prophylactic reasons, to prevent infection, to enhance the likelihood that animals will be able to be transported in a healthy way. So these antibiotics are used widely in agriculture with livestock, and there is a growing concern that the rise of antibiotic resistance is really required. In order to control that, we have to address this use of antibiotics, not just in clinical settings, but also in terms of agriculture applied to livestock.